Okay, is majority of you guys back? I can't see anybody.
Yes, sir. We're pretty much all here.
Awesome. Okay. So I probably should have just continued on the last one because we only have a very little bit left to go. So let's go ahead and finish this up. So we've talked about some common things, benign GI disease, mechanical obstructions, IBD, things like that. Now we're going to talk about malignant GI disease. And the whole deal with malignant GI disease that you really need to know is when you have a malignancy, such as an adenocarcinoma or lymphoma or one of the smooth muscle tumors that live in the bowel wall itself, typically it causes thickening of the bowel wall. And the key is you have now disruption of those normal layers. So now you do not have distinct layers. Now it's all because whatever tissue this is, whatever the cancer is, it's destroying the layers as it eats and thickens the bowel wall away. And so you get thickening of the bowel wall and destruction of the normal layering appearance. So here, this is a section of thickened bowel wall. This is the white line. That's the lumen that's going down. That's got a little gas in it. But now if I measure the thickness, it's super thick. It's 1.1 centimeter thick about, and you have no layering definition at all. No, none of it whatsoever. And if you go to the other side, here's the lumen, here's the other side. And again, there's no layering definition. That's because whatever is living in there, in this particular case, it's lymphoma or lymphosarcoma. We have all these neoplastic cells that live in the bowel wall itself, and they're making it super thick and destroying the normal layering that's in there as they infiltrate into that bowel. So the key is thickened bowel wall with destroying of the layering. Here's another section of bowel. This is the lumen. These are little reverberation artifacts by a little bit of gas that's in the lumen. Can't really see the other side well of the bowel wall because of the gas. Okay. But this side you see really well. So super thick here, not as thick here, but super thick here with no layering at all. Anytime you lose the layering definition, that should tell you there's something much more aggressive happening in the bowel wall. And typically it's going to be usually lymphoma, lymphosarcoma, same thing, or an adenocarcinoma that lives in the bowel wall itself. In that particular case, it's easy. You can put a needle right into the bowel wall itself, and you can withdraw some cells and look at those cells under the microscope and usually make a diagnosis. This is the same thing. This is part of the stomach. So that's a little bit of ingestion gas in the stomach, but super thick stomach wall, measures up to 8 millimeters. You can see here in thickness. And complete lack of layering definition. So that's something is aggressive that's living in that stomach wall. And again, that case, it was lymphoma. This is another linear form body, but the bowel wall also looks thickened in that area too. So he's probably got two problems anyway going on. This is another area of bowel. This dog ate some kind of a toothpick or skewer or something that was stuck in the middle of the section of bowel. So just a couple of examples. This was a weird one. This one, I had no idea what this was. It looked like some kind of heterogeneous egg-shaped thing in this dog's abdomen, kind of in the mid-abdomen. I was betting it's some kind of cavitated lymph node. I had no idea what it was. And it went to surgery, and they took it out surgery. Well, this thing happened to be connected by a very thin, like 2 millimeter long little stalk to a section of bowel. And it turned out that was a bowel wall tumor, but it's not was in the bowel wall. It was connected to a section of bowel, and it was a leiomyosarcoma. Was the way the histopath was read out on that. So who knows? Even to this day, I still see things from time to time that I really have no clue what they are. And then you just describe the hell out of them and do your best that you possibly can. Okay. Other things that we can use ultrasound for, again, we want to look at the peritoneal space. You probably talked about this condition a little bit with Dr. Warner. So this is a congenital hernia. There's the heart, there's the liver, and there's this connection between the heart region and the abdomen. That is called a peritoneal pericardial diaphragmatic hernia. It's almost always congenital. Okay. Remember, embryologically, when the diaphragm forms, it kind of forms, it's kind of like a garage door. Okay. It kind of forms from top to bottom. And as the animal develops embryologically, it should shut. Okay. And that when it shuts, that should divide the thoracic cavity with the abdominal cavity. If for whatever reason, as they're developing, the garage door fails to completely shut. So this part of the garage door shut, but it got stuck right here. So it allows this connection between the abdominal cavity and the heart. Okay. In reality, it's not connecting to the heart, it's connecting to the pericardial space. Okay. So in this case, this animal has some fat, falciform fat, that is herniated around the heart into the pericardial space. That's called a peritoneal pericardial diaphragmatic hernia, and it can be fixed. Okay. This particular cat just had fat up there. Sometimes they'll have the liver up here next to the heart. Sometimes they'll have a bunch of small bowel loops and even colon up next to the heart. So anytime you see bowel loops in the region of the heart, obviously that's probably not normal. Okay. So this was the connection. That's part of the heart here. It's kind of hard to tell, but that's a little section of fat and probably a little bit of liver. So that's the edge of the diaphragm. Here's liver here, but it doesn't complete itself. Okay. The diaphragm is incomplete, and it allows some of this tissue, fat, falciform fat, and liver to go up next to the heart in the pericardial space. Free fluid. What do we see with free fluid? Again, how much, if I asked you on a test, if I said, how much free fluid should a normal animal have in their peritoneal space? And your answer should be 2 or 3 drops. Okay. Just a teeny bit. Okay. If they have any more than that, that's abnormal. And then you try to figure out, well, why do they have that free fluid in there? We know it's not normal, but why do they have it? And you want to characterize the fluid like we talked about before, which means, does it have little speckles floating in it or not? Well, one of the best places to look for peritoneal fluid is right next to the urinary bladder on either side of the bladder, what I describe as the gutters of the bladder on either side of the bladder. So here's a urinary bladder. It's thin and smooth. It's got some fluid inside of it. And outside of the bladder, we got all this fluid next to it in the peritoneal space. And if you look, that peritoneal fluid compared to what's in the bladder has a bunch more echogenicity, a bunch more cellular debris inside that fluid than what's inside the bladder. Bladder's a lot more black, anechoic looking than this is. So that should tell you there not only is there peritoneal fluid, but there's something floating in the fluid, whether it be protein, cells, white cells, or red blood cells. So something is in there. So it's either probably going to be, if it's got speckles in it like that, it's either going to be a modified transitate or pure blood, like a hemoabdomen. Okay. So that's one of the best places to look, right on either side of the bladders, the other side of the bladder. This is a kidney here. And again, all this is fluid around the kidney, fluid over here. And again, if you look at that fluid, it's got speckles all inside of it. So it's probably either a modified transitate or a hemoabdomen with blood. Okay. Here's another part of a kidney. This is a section of the liver. And again, this little triangular area here, in this case, it looks pretty anechoic, pretty black. So that may be just a pure transitate inside. But in either case, if you see free fluid, for the most part, you always want to put a needle into it and get a sample of it, look at it under the microscope, and see what kind of fluid it is. Is it a pure transitate? Is it a modified transitate? Or is it hemorrhage? Okay. There's a section of bowel, and again, there's a little triangle area of free fluid. And again, you can put a needle in that. You can be really accurate with ultrasound with a little practice, and you look at it, that free fluid, and try to decide what kind of fluid it is. Here's a abnormal looking liver. This is the edge of the liver. The margins are irregular in shape. It's got mixed echogenic mass lesions or nodules in it. It's got one bulge in the capsular surface here, but it's got a lot of free fluid in the peritoneal space surrounding this ugly looking liver. So that fluid may be arising from the liver. It may be like a modified transitate that's leaking out of the liver because the liver now has some type of, most likely, neoplastic condition involved. Okay, another bladder. Here's a little triangle fluid, more fluid down in here. Okay, you get the idea of how to look for peritoneal fluid. Sometimes you'll see debris in the fluid, and sometimes they form actually these little spider web looking things. These are called fibrin tags, and they connect one organ surface to another organ surface. And in real time, they're floating around. It's like in slow motion, and you can see them like a spider web in the breeze. Okay. And so these are called fibrin tags. They don't mean anything other than that usually tells you the fluid in the peritoneal space has been there for quite a while. That allows it to have these depositions of fibrin inside the peritoneal space. Okay, miscellaneous stuff that we can look at with ultrasounds, not just abdomens, not just hearts. We can look at small parts. We can look at thyroids. We can look at the brain. Sometimes we can look at eyeballs. We can look at the retrobulbar space behind the eyeballs, things like that. So other uses for this. And remember, we talked about a dog like this when we talked about a long time ago, Neuro. And this dog has one of those big dome-headed dogs. It's kind of smoothed out in here. We don't see those normal convolutions very well. It's got a big open fontanelle, okay? And so I said, but even back then, that one of the ways to diagnose hydrocephalus in a dog, if they have an open fontanelle, that is your window. That's your opportunity. Stick an ultrasound probe there and look inside the brain and see if you see big dilated ventricles. If they don't have an open fontanelle, ultrasound is not going to help you because it won't penetrate through bone. Then you'd have to do CT. Okay. This dog also has occipital dysplasia. That's the extension of that foramen magnum going dorsally. But here's that big open fontanelle that we can see. And if you look with ultrasound, look at this great big dilated ventricle here. That's the mid portion of the brain, or the falx cerebra. Okay. Here's the other lateral ventricle over here. Great big dilated ventricles, very thin rim of surrounding cortex of the brain. Okay. So this dog's probably going to have some neurologic issues and at least be mentally dull. Otherwise known as a normal Chihuahua. Okay, eyeballs. You can look at eyeballs. So here's an eyeball here, and you haven't had ophthalmology yet, and so the anatomy of the eyeball you might not be that familiar with, but you can see this part in here is the lens. The lens should always be pure black, pure anechoic. This is the anterior chamber of the eye in the front part. This is the posterior chamber, or the vitreal chamber back in here. And again, all of that should be pure black, and the eyeball should be perfectly round. Okay. This triangular area here is what's called the retrobulbar space, and usually it's filled with fat, and somewhere through there is the optic nerve that passes. Okay. And again, some dogs will get mass lesions or abscesses or big granulomas that can live behind the eyeball and cause flattening of the caudal aspect of the eyeball. And typically it'll push the eyeball forward physically so you can see it, which is called exophthalmos, or of the eyeball. Okay. So anyway, so we look at the eyeball itself. We can look at the anatomy of the eyeball. We can look at the retrobulbar space, all with ultrasound, to see if there's an abnormality in there. In this particular case, this lens is flat. It's got echoes in it. So the lens is fractured. It's actually ruptured, the lens of the eyeball. And he's got all this floating crap back behind there in the posterior chamber of the eyeball. And that's hemorrhage back behind the lens inside the eyeball. Okay. Here's another one. The lens is fractured with a little bit of debris inside that posterior chamber. Okay, thyroid glands and parathyroids. This is the thyroid. This whole thing here is the thyroid gland in this particular animal. Remember, on the parathyroids regulate calcium in the body. We kind of mentioned that at the end of the neurologic section. We talked about parathyroid adenomas. And if you look, this is a little like hypoechoic area. Remember, each thyroid has two very small parathyroids associated with it. And this one it's pretty prominent. If I blow it up, here it is again. And this is the problem this is a parathyroid adenoma. So this is a functional tumor. It's usually benign, but it is functional and it's making too much parathyroid hormone, which causes the animal to become hypercalcemic. Okay, so you can diagnose parathyroid adenomas with ultrasound pretty easily. And then typically after that, the surgeons can go in and take that out. There are some people that will ablate these. They put a needle in them and inject ethanol alcohol into that, and it will kill that parathyroid adenoma. Okay, you have to be real skilled and careful to do that, because if you miss and you get some of that ethanol outside of it, there's the nerve that runs right through there in that same region called the recurrent laryngeal nerve, if you remember from anatomy. And if you get that alcohol near that nerve, it can nuke the nerve essentially, and then you will create a dog that has laryngeal paralysis. So you got to be real careful if you try to ablate these. Most of the people will just take them out surgically. Miscellaneous. This was, I think, an egg-bound iguana. No, it's a parakeet, egg-bound bird that you can see. So this is a non-mineralized egg that's sitting in the coelomic cavity of that bird. This was the egg-bound iguana. So I think this is one in Cayman I did years ago. So this is a non-gravid, mineralized, partially mineralized egg in the coelomic cavity of that iguana. Okay, and then interventional ultrasound. Just a couple of thoughts about interventional ultrasound, which means you're going to hold an ultrasound probe in one hand, and you're going to hold a needle and a syringe in the other hand, and you're going to stick it in and use your ultrasound to guide it and exactly where it's going. Okay. Most of the time, with a little bit of practice, you can become very skilled with this, and you can hit any nodule that may be more than about 4 millimeters in diameter. You can hit with a needle using ultrasound guidance. Okay. One of the best ways to practice this when you get out and you have an ultrasound machine in front of you is you go to the grocery store and you buy, go down the row where they sell fruit cups. Okay. And you want to find a set of fruit cups like that has water in it, and then it has chunks of like pineapple and peaches and pears or grapes or whatever's in there. Okay. And you want to find the fruit cups that don't have the aluminum foil metal kind of top. It has a plastic top, like a little thick plastic top. Okay. And those are really good to practice on your skills of fine needle aspirates, because you do with those, once you get the right kind of fruit cup with the plastic top, you don't take the top off. You just keep the top on it, and you put ultrasound gel on top of the fruit cup on top of that plastic top, right? And you can see the fruit, and it's real pretty. It shows up really nice with ultrasound. And then you use your needle to practice. You just stick right through the plastic top to try to get practice on sticking something. And doing that a little bit, you can get really skilled. And again, you can hit anything that's greater than probably 3 or 4 millimeters in diameter and be really, really accurate in doing it. Okay. So that's one of the easiest, cheapest ways to practice fine needle aspirates. Of course, another good way is if you have a dog that is just expired and you know he's got, you put him down or whatever, he just died, and you know there's some kind of pathology in his abdomen, and you can ultrasound the abdomen. If you see something, you can get practice doing fine needle aspirates in that scenario also. Okay. I'm not going to worry about that. So here's an example. Here's a tumor here. Here's the needle going into the tumor that you can see here, that straight line. So we know we're right in where we need to be to get the aspirates out of that tumor. Okay, I think that is it. The end of the ultrasound lecture. So let's talk about your exam on Monday. Your exam on Monday, again, Dr. Charlie Dickinson will proctor it. And your exam this time, it only will cover ultrasound. Okay, so from when I started talking about ultrasound, so a lot less material for this exam that you need to worry about. So review your ultrasound lectures. I'll send you these last two here in just a little bit today. Review those, study, do your part again this weekend. The format of the exam will be the same, multiple choice, 4 possibilities for each question. There will probably only be 25 to 30 questions this time, since it's a lot less material. So, but only ultrasound. Hopefully you do well. You did really pretty well the last time. You know, and I'll give you the rest of the time today and tomorrow. I would hopefully you can use that time studying for the exam, and maybe study a little less this weekend if you use that time tomorrow for the exam. Okay. So any questions, you know, before we leave? I've enjoyed teaching y'all. Hopefully you've gotten something out of the course, with Dr. Warner and I both teaching our parts. If you have questions, you can email me. If you have questions even after the course, or anytime you get in the Houston area and you want to come by and say hi and visit, please do. So any questions before we hang it up today?
Thank you. Thank you so much. Thank you.
Yeah, no problem. It's not as good as being there, but we made the best of it anyway. So again, this weekend while you're studying, let me know if you got questions and we'll go from there. See y'all.
Bye.